All right, so this is chapter 14. This is the last couple of chapters we're going to cover. 14, 15, and 16 will be on the final. There's not going to be a test 4. There's just going to be a final. And I don't know how I'm going to do that yet, so don't ask. All right. For me, it's April 4th. This is before your test 3, but this is not on test 3, okay? So even though I'm uploading this video right away, this stuff is not going to be on the third test. So do not study this for the upcoming test. Okay, I can't make that any more clear. So we're going to talk about the spinal cord. And the spinal cord is a confluence of matter that comes from the brain, goes down the spinal column, and it's part of the central nervous system, but it's not part of the brain. Everything below the brain stem is considered spinal cord. All right. So this is spinal cord functions. It does conduction, right? Information down and up from the body. Locomotion. There's some crude pattern generators, kind of reflex type things, located within the spinal cord. So even if you have a lesion, when we say lesion, we mean a cut, basically, either from trauma or from a tumor or lack of blood supply that killed the nerves. Like say here, there's still some patterns of movement of the lower extremities that will happen even without any innervation from the brain at all. So if you take a person that has recently had a spinal cord injury and you hold them up and put them on a treadmill, their legs kind of make a crude approximation of walking. Just like you can take a baby, a little baby that doesn't learn to walk at all, and kind of put his feet on the ground and the feet kind of do this. Okay, that's because there's some locomotion functions that come from the spinal cord that's just innate as part of the spinal cord. And then the reflexes, when you tap on your knee and that knee shoots out, you got lots of other reflexes, we could go through them. That happens at the spinal cord level. That information doesn't have to go to the brain to be processed and decide to kick your knee. It happens at the level of the spinal cord. We'll talk about that some more. Okay, so we're going to talk about the anatomy of the spinal cord itself. So we divide the cord up into this thicker region, a skinnier region, and then a thicker region again. This thick region that's part of the cervical vertebra is called cervical. It's clever naming. And then the part that has ribs, every vertebra that has a rib is a thoracic vertebra. And we call that part of the spinal cord thoracic. And then there's the lumbar area, which goes down to the level of the sacrum. And then the part that comes out the sacrum is your sacral stuff. Below that, there's just some loose nerves that they call the cauda equina because it looks kind of like a horse's tail. It's just a loose bunch of nerves below where the spinal cord ends. Okay, so it's thicker, like I said, in the cervical area and in the lumbar area, and thinner. In the lumbar area and thinner in the thoracic area. That's right. Where the spinal cord comes to a point, they call it the medullary cone, and below that is the cauda equina. Here's some pictures of what it actually looks like. You can see why we use the cartoon. It's hard to make heads or tails of this. Okay, and just like the brain has the meninges, so does the spinal cord. So that thick outer part is the dura mater, and then that thin web-like vascular area is your arachnoid space and your arachnoid mater, and then the thin part attached to the spinal cord itself, that's your pia mater. Okay, the spinal cord is attached, the cord itself is attached by this filum terminae, and as long as it isn't attached too tight, it keeps the spinal cord in place. If that breaks, then the spinal cord retracts up and pulls on the nerves and does damage. If it's too tight, you can actually start having some nerve damage. And I usually have a story about that, but we're going to skip that. Okay, if you're going to be an anesthetist, which I know a lot of you are planning on being a nurse anesthetist, you're going to spend a big chunk of your day doing epidurals and different types of spinal anesthesia. And so you're going to know this anatomy super well. You're going to be exposed to it over and over. But everybody needs to understand, when we talk about what a lumbar puncture is, what's happening with a lumbar puncture. Okay, so in theory, when you want to do one of these spinal blocks, either a lumbar block or a lumbar puncture, you want to be down below L2, because in an adult, the spinal cord ends around L1, L2. All right, so you want to be below there. Where you put in the needle, you want there to just be some loose nerves and not the spinal cord proper. They used to do spinal taps way up high all the time, and most of the time it worked out. So I'm not saying it's the end of the world if you go up, but in general, this is where you want to be. So this picture shows it between L3 and L4. Kids' spinal cords go a little lower. So when I do spinal taps on babies, I'm real low. I go like L3, L4, and if I don't have any luck there, I go down between L4 and L5. And so it works best if the person or the baby's in an arched position like that. That lets those wings of the vertebra open up good so you can get the needle in there through all this, through the skin, through the fat, through the muscle, through this thick connective tissue, and then through the dura mater and the arachnoid mater into this area. And if you go all the way through, well, there's some blood vessels over here, and you find out when you get a bunch of blood back, you went too deep. Okay, the needle's inserted, and you know, there's a pretty good pop when you go through the dura, and then that's when you stop. You know, you're deep enough. Now, if you're doing epidural anesthesia, you stop before you go through the dura. You're just putting it here, and that gives you spinal anesthesia. It blocks all these spinal nerves without actually entering this, and that's done a lot now too. Like I said, if you go into anesthesia, you're going to learn all about it. All right, so the anatomy that you can see of a spinal cord. So this is a picture of a spinal cord that's been cut cross section, you know, horizontal, transverse like this, and you can see the matter here. Now, different from the brain. You know, in a brain, the gray matter's on the outside and the white matter is in the middle. On the spinal cord, it's the opposite. The gray matter's in the center and the white matter's on the outside. So all the tracks of the white matter going up and down. The gray matter is where communication happens to the spinal nerves themselves. Okay, so this, you know, this is the back and this is the front, anterior, posterior. So these are the dorsal horns or the posterior horns, and here's the anterior horns, and this is your lateral horn. Okay, that makes sense. Okay, the white matter is the tracks, that's on the outside. And so there's columns, posterior columns, and then ventral columns, and then lateral columns. So this is axons going up and down the spinal cord to wherever they're going up to the brain. Okay, these are the ascending and descending tracks. Some years I spent some time trying to sort this out. We're not going to do that this year. Okay, so we're going to talk about ascending tracks. Ascending means going from the body up the cord to the brain. So you know that's sensory, right? Whether we're talking about sensory information that's somatic or sensory information that's visceral, right? The autonomic system. This is information going from the body up through the spinal cord to the brain. And I know it's sensory because it went through the thalamus here. Remember, the thalamus is that filter, that sorting filter for sensory information. And so sometimes the information crosses at the level of the spinal nerve right there across that medial area, and sometimes it crosses up in the pyramids, you know, up here in the brain. You just need to know that. We're not going to get into the details of this. Okay, descending track, so this is information going from, you know, that front part of your brain that goes to control muscle. And so some of that information crosses in the pyramid, some of it crosses at the level of the spinal cord and controls whichever muscle is going to be controlled by. Sounds like it's storming outside. How about that? All right. So we're going to look at the structure of the spinal nerve and the ganglia. You know, the ganglia, those fat parts right here, that come from the posterior horn. And that's a bunch of satellite cells, those satellite cell bodies here that are in the ganglion. Okay. These are a bunch of axons bound together by connective tissue. And then, of course, there's the perineurium and the epineurium. Peri being right around the nerves, and epineurium is the connective tissue that holds the whole thing in. Okay, we can classify nerve fibers as either afferent or efferent. Afferent carry signals from receptors to the CNS, right there. Ascending, afferent. Efferent, exit, exit, carry motor signals from the CNS to the effectors, wherever they're going. Somatic fibers, these innervate skin, skeletal muscles, bones, and joints. Visceral fibers, blood vessels, glands, and viscera. So this is the stuff you don't have control of, that you're not aware of. This is stuff you do have control of or aware of. All right. Spinal nerves. There's 31 pair of spinal nerves. You have to know that number. I'm going to ask you that number on the final. 31 pair of spinal nerves. There's a dorsal root and a ventral root. Okay? Uh-oh. And the dorsal root has the ganglion that we just mentioned. There are distal branches that come off, and then anterior branches. So in the thoracic spinal nerves, this posterior root controls the flexor muscles that make your neck and back do like that, and then the anterior roots go to other places, either to the sympathetic ganglion or kind of track along your ribs. So they have autonomic and somatic properties. All these nerves are mixed. Okay. All right, dermatomes. Notice this shows this anterior ramus tracking along the rib. And so what that means is that tends to go in this groove right below the rib. So when you're going to put a chest tube in somebody, either a baby or an adult, you always want to hit the rib and then go above it so that you don't ruin these nerves, because you can cut one of these nerves with a needle and then you lose innervation here forever. So you hit the rib and go above it, always, not below it. Below it is where that artery, vein, and nerve run. Okay. Notice there's dermatomes, so if you have a loss of sensation, you can tell which ramus you've lost. And this picture is specifically showing you someone with zoster, with shingles. Shingles tends to track along a single or two different dermatome because it lives in your nerve ganglia. Once you've had chickenpox forever, that virus is there in your nerve ganglia and can come back to give you shingles. That's why they show this picture. And you can tell the dermatomes based on these pictures. And this also lets you know, like when you have spinal cord compression, like if one of these, you get damage to that big old disc between your vertebra, and that disc bulges and hits against your nerves, you can tell which nerves are being affected by where they have either pain or loss of sensation along their legs here. Okay, so as the nerves exit the spinal cord, your spinal, what we're talking about, your spinal nerves, they tend to join back up in very specific patterns. Like, it's not random at all. It happens over and over again. So we humans have these groups of spinal nerves that have clumped together to form new nerves that we call plexuses. Okay, you have a cervical plexus and a very important brachial plexus here, and then your lumbar plexus, and finally your sacral plexus and your coccygeal plexus. Okay, you don't have to learn every one of the nerves that comes from these, but there's 4 or 5 big ones that you have to know about because these are important nerves. And that cervical plexus and your brachial plexus are very important, involved in any kind of shoulder or neck injury. Okay, if you get a blow to this shoulder hard enough, it can damage that brachial plexus and cause loss of function of your arm. So it's actually pretty common. Football players will hit their shoulder hard enough that they'll have what they call a stinger, and for a while they have this burning sensation in their hand, and their hand doesn't work right, and after 15 or 20 minutes it comes back. A much more severe injury will actually tear those nerves of the brachial plexus, and then that's it. You lose that function of that arm. It doesn't come back very well. All right, so let's talk about the cervical plexus. Notice it has some connection, the plexus has some connection with the cranial nerves that we mentioned earlier that come down 12 and 11. The accessory muscles, the accessory nerve controls the way your shoulders rise. And that makes this ansa cervicalis, this circular pattern of all these nerves that come together to form new nerves. And at the bottom here, we have the phrenic nerve that's innervated by C3 and C4. And so what that means is the phrenic nerve controls your diaphragm, controls breathing. So if you have a spinal cord injury here, even though it's way up here, you still can breathe. You can control your diaphragm. However, if it's above C3, you no longer have a functioning diaphragm. So people that have spinal cord injuries above C3, like the guy, Christopher Reeves, that played Spider-Man, his was very high. He couldn't breathe for himself, so he had to have a ventilator breathe for him. Okay, the brachial plexus, these are this group, 1, 2, 3, 4, 5 nerves, C5 through T1, that merge in different ways to make these 3 big nerves that run down your arms, and then branch again into 5 nerves total: median ulnar, axillary radial, and musculocutaneous. Okay. And then finally down at the bottom, the lumbar plexus. This gives you your femoral nerve and your obturator nerve. Those are important. The femoral nerve runs anteriorly, so when you're drawing blood on somebody here, which we have to do sometimes, or put a central line, or do a cath on somebody, you got to know where that nerve is, okay? Because you cannot hit this big nerve. It will have permanent damage to all the innervation of the leg. So here's your sacral and coccygeal plexuses. This forms the biggest nerve in the body here, your sciatic. This runs back in towards the back, and so people sometimes have pain in that depending how the muscles are pressing on it. And this gives you all these nerves. The common fibular and tibial. The pudendal comes from the coccygeal, and this controls your anus and your sexual organs. All right, let's talk about reflexes very quickly. Sensory receptors is required for a reflex to work. There has to be some place that recognizes that there's an effect on the body. And then there's the neurons that go to the spinal cord, and then there's association neuron in the spinal cord that communicates the sensory to the motor to send it right back to the area that was affected and affect the muscle or gland, the effector. Okay. So this video shows pretty good what's happening. So you have these effectors in the skin or in the tendon that are affected. The information goes to the posterior horn, and then there's communication through these association neurons, sometimes on both sides, depending which reflex it is, and then goes straight back to the muscle that's going to be affected. So you have one there, you know, if you tap on this big tendon, it'll make this muscle short. Okay, same thing here. You can tap on either side or up here and get that muscle to shorten here. All along here, there's little reflexes you can tap and make each of these fingers move independently. And of course, there's that great one right below your kneecap that they often test. Here's just a picture showing a couple of different kinds of reflexes that you need to be familiar with. So here's some stretch fibers. When that muscle is stretched, it tends to want to contract, and that's because, you know, if all of a sudden your muscle gets stretched real fast, that muscle needs to start contracting to keep it from tearing, and you may not have time for the brain to decide, oh, I think I'll contract that muscle. So this happens at the level of the spinal cord, and it saves you that time going up the spinal cord and back down. Okay, and this last one, this is just a crossover extensor reflex. So this is why, you know, if you step on something sharp or hot, you'll retract that foot before the brain even appreciates what's happening. And you know, if you just picked up your foot, you'd fall, right? So there's some innervation at the spinal cord level that crosses to tighten up the other leg so that you'll pull that foot off and still not lose your balance. That's what this picture's showing. Okay, so that's the end of spinal cord and spinal nerves, and we're gonna just get through this information there. I know you'll have other classes too, and it's a struggle right now, but we got to get this done, guys. I mean, you signed up for it, kind of not knowing what was coming, and here we are. So I'm gonna get through it with you. All right, that's all.